Good evening, everyone. Happy New Year, though we are in February. I'll say that because it's the first KDSG webinar that we are having online. So we want to welcome everyone to this webinar tonight. I think the topic is quite exciting, as you can see. We are going to be discussing semaglutide as a paradigm shift in the management of cardiovascular risk. And our presenter for the year for this first presentation will be Dr. Olive Akunga. It's indeed a pleasure to introduce Dr. Olive. She's a consultant physician, medical epidemiologist, and endocrinologist with keen interest in obesity and metabolic medicine. And she currently serves as the head of the education subcommittee in KDSG, and she works at Mater Hospital, Nairobi, where she is the head of internal medicine department. She also serves as the program coordinator of EXACOP. EXACOP means East, Central, and Southern Africa College of Physicians Internal Medicine Training Program. So as we invite Olive to come and do this presentation, we also want to acknowledge it was possible because of our sponsors. And I know they'll also get a chance to say something about this drug towards the end of this presentation. Otherwise, because I know there'll be a lot of questions and we also want to learn so that we don't run out of time, let's all welcome Dr. Olive so that she can be able to start us off this evening.
Thank you so much, Dr. Omari. I hope you can hear me clearly.
Yes, we can hear you.
Okay, great. Thank you so much once again for that kind introduction. We'll get right into it. And our discussion today will be around semaglutide, which is a GLP-1 receptor agonist. GLP-1, for those who are not familiar with the acronym, is the glucagon-like peptide 1, which is one of the two major incretins produced by the body. So semaglutide being a highlight GLP-1 receptor agonist will be our main focus of discussion. And once we get into it, we'll be able to look at the basic concepts of obesity, diabetes, and cardiovascular disease. So what is this overlap? Why are we always mentioning these three together? So we'll look at how it is that they interact across the three complex diseases. And then we'll have a look at the pathophysiology of cardiovascular disease in obesity and diabetes, or what we call diabesity. And then we'll look at an overview of the GLP-1 and GIP therapies. So that's basically an overview of the incretin-based therapies. The role of these incretins in terms of cardiovascular risk reduction, and why we are so interested in terms of these medications. Of course, initially designed in the treatment of diabetes, but now a lot of other indications coming out strongly, top of which is cardiovascular risk modification. And alongside that, we'll look at the concrete evidence. You can't argue with science. So if we are claiming any benefits, what is the scientific evidence behind it? So we'll have a look at some of the anchor trials, and then you can be able to make an individual decision as to whether indeed semaglutide is the game changer as far as CV risk modification. So as a matter of introduction, diabetes and cardiovascular disease, when you look at the data, and there is aggregated data by Regassa et al., published in 2021 in the New England Journal of Medicine, you find that the cardiovascular disease affects up to 42% of individuals with type 2 diabetes. You'll hear me referencing type 2 diabetes a lot because remember, most of these medications are only now being widened in terms of the scope of use in type 1 diabetes, but the concrete evidence exists in type 2 diabetes, hence the repeated mention of that particular subtype. Global studies indicate that about 50% of type 2 diabetes patients have clinical obesity. And of course, it goes without saying that diabetes and obesity are both associated with significantly increased cardiovascular morbidity and mortality. And we'll look at that in detail shortly. Now, because of this heavy overlap, there is an unnegotiable shift in terms of diabetes care at the moment from glucose centricity, where initially, and this is probably 10 years back, where diabetes treatment was mainly focused on the blood sugar target, and now a total shift in the last decade to a cardiorenal metabolic approach, where you're looking at not just the effect of the medication you're giving in terms of achieving your glycemic target, but you also want to ask yourself right from the outset, way before those complications develop, are these medications designed to reduce the risk of my patient as far as cardiovascular disease, as far as renal function deterioration, and are they also contributing not just to the glucose effect, but overall metabolic wellness, including things like weight management? So let's recap a bit because I know diabetes, obesity, heavy terms. For those of us who need a bit of a refresher, when you're in a primary healthcare setting, and I chose to put this slide up because I know we have different cadres joining the webinar, including our clinical officers, nurses, and so on. The diagnosis of type 2 diabetes, by definition, would be a HbA1c, which basically looks at the 3-month average of your blood sugar, so under 6.5%. And remember to use a method which is certified and standardized for this. So this would be preferably a laboratory parameter, which is able then to give you the cutoff of 6.5%. Now, what does it mean if it's 6.4 or 6.3? So normal would be below 5.8%. Some guidelines are even more strict and quote 5.6%. But in general, 5.8% to 6.4% would be your pre-diabetic range. 6.5%, that particular individual qualifies for to be onboarded on treatment for diabetes. Remember also for pre-diabetes, depending on what comorbidities the patient is presenting with, you may decide to start on monotherapy and so on. But I won't get into that because it's not the primary focus of our discussion today. Fasting plasma glucose above 7. And when we talk about fasting, we're talking about a period of at least 8 hours where the person the individual you're testing has had no caloric intake. So even if they've consumed any beverages, then they need to be those that don't sort of spike an insulin response. Things like, black coffee, no sugar. There are those instructions that we give, particularly to patients who are coming for fasting tests. The same apply. And then when we look at so that's for non-pregnant individuals. When you look at the pregnant population, where we mostly use the OGTT, the cutoff would be 11.1 millimoles per liter. And then also you can base the diagnosis on an individual who presents with classic symptoms of hyperglycemia or in hyperglycemic crisis, things like DKA, with a random plasma glucose of above 11.1 millimoles per liter. In terms of obesity in the primary healthcare setting, remember as of August 2024, obesity now has a code, an ICD-10 code. What that means is that we now recognize it objectively in the clinical setting as a chronic disease. So code number E66.0, if you look up the ICD-10 list of diseases, you're now able to actually classify your obesity patient as objectively having a disease requiring medical therapy. So initially in the past, BMI is what we mostly referred to, but now it is agreed and passed by the World Obesity Federation that BMI as a standalone is inaccurate in terms of defining clinical obesity. You must include other parameters. And the reason for this is that when you look at the literature review of the correlation between BMI and cardiovascular risk, it does not correlate as strongly as body size or fat estimation. Now, how do you estimate body size or fat in a clinical setting? Very basic anthropometric tests, actually almost at no cost to the patient, which is a good thing, particularly for low resource settings, like is the case in most of the clinical facilities in our country. You can use your waist to hip ratio, and the cutoff for men is 0.9, 0.85 for women. A waist to height ratio, which across board is 0.5, or a waist circumference, which is an upward value of 35 inches for females and above 40 inches for males. Now, those three anthropometric measurements, when you look at the data, the published data around how they correlate with cardiovascular risk, they have actually been found to be very significant. So, it is necessary for us in our facilities, because what we are doing is using new evidence, using data to be able to inform our daily practices. So for those of you who are on the call and have an influence as far as what triage data comes to you as the healthcare provider, maybe you want to modify the triage data to include some of these parameters, even something a standalone like waist circumference, so that as you see the patient, you're not just basing your patient profiling on their weight and their height, which gives you the BMI. You can have a waist circumference that immediately now gives you a high index of suspicion in terms of their cardiovascular risk and what medications you want to put them on, or what kind of interventions you want to suggest to the patient. Other things like the DEXA scan, which is more sophisticated, of course, comes at a cost to the patient, can also be used, or calculations like the visceral adiposity index, which also correlates very well with those anthropometric measurements that we've just talked about, and is also a low-cost alternative to the DEXA scan. The other thing you have to include in terms of clinical definition of obesity requiring medical assistance or medical therapy would be comorbidities. When we talk about comorbidities, we're talking about diabetes, we're talking about cardiovascular diseases like hypertension, heart failure, and so on, reproductive health, bone health, mental health, and so on. So comorbidities across board, because remember, obesity is a complex syndrome affecting almost every organ in the body. This is a summary of what we mean when we talk about clinical obesity in the current scope of definition. You can see at the top of that diagram, your BMI indices as we knew them traditionally, where a BMI upwards of 24, you've started entering the risk category. And once you scale above 30, then now you're clearly in the obesity category. That was in the old diagnosis. If you look at the fourth row of the diagram that is on your screen. Now, in terms of how we define it currently, you need to know which of your patients has preclinical obesity, which patients have clinical obesity. When we talk about clinical obesity, what you mean is who requires a structured approach in terms of medical assistance to be able to manage their weight. Why? Because that obesity is not just about their weight, it's about all the other multi-organ effects of that particular syndrome, if I may use the word. So you want to know if their BMI is high, do they have excess body fat by those estimations that we've just talked about? Yes. Do they have any comorbidities? No. Then they probably fall in the preclinical obesity, and you can go conservative as far as their management. Is their BMI high? Yes. Do they have excess body fat? Yes. Do they have clinical signs and symptoms of any kind? Elevated blood pressure, which could be pre-hypertension or clear hypertension. Do they have dyslipidemia and so on, and all those other things that we talked about, including mental health, because things like depression, anxiety disorders, and so on have now been associated with with obesity and so on. So you need to look at your patient holistically, assess whether you have any comorbidities in addition to the excess body fat, and determine where your patient falls. We won't look so much into the definitive treatment of obesity, maybe in a different webinar. I know we've done that before. Today, we want to focus on the overlap between this diabetes and cardiovascular disease and how the GLP-1 arrays come in when it comes to management. So the key connections between diabetes and cardiovascular disease would include things like heart failure risk, where obesity causes structural and functional changes in the heart with specific proteins linked to increased heart failure risk. You also have higher insulin resistance and pro-inflammatory uh, uh, biomarkers and cytokines being released in both obesity and diabetes, where we know they cause a chronic state of low-grade inflammation with endothelial damage to your blood vessels. And then you also have fat accumulation, basically increased visceral and ectopic fat, which impairs heart function. And we will look at this in a bit more detail in the next few minutes. And of course, in diabetes, your glucotoxicity and its attendant effects as far as microvascular complications as we know them. And in addition to that, the interlinkage between the glucotoxicity and higher potentiation of atherosclerosis. The mechanisms implicated in obesity and adverse myocardial consequences, similar to what we've just mentioned. But when we look at them as umbrella mechanisms, we mainly talk about hormonal, inflammation, and autonomic dysregulation. If we can give an example of what happens in the renal system, where you have compression of your renal structures by visceral adipose tissue, causing an increased sodium reabsorption before the filtrate gets to your macular denser cells in the distal tubule, thereby activating your renal angiotensin aldosterone system that partly gives rise to CKD and hypertension. So you have that RAS activation because of that increased adiposity around your renal structures. When we look at the autonomic dysregulation, you find that through dysregulation of your afferent autonomic receptors, like chemoreceptors, and secretion of your adipokines, for example, your leptin and so on, obesity-induced sympathetic activation potentiates the risk factors that contribute to cardiovascular disease. Now, when we summarize that in terms of the three pillars of the mechanisms implicated as far as your myocardial consequences, and here we're talking about cardiovascular risk. As I've mentioned, you look at the pro-inflammatory potential of that excessive adiposity, the neurohormonal consequences, as well as that autonomic dysregulation that I've just talked about. And you can see on the left-hand side of the screen what happens when you have those pro-inflammatory molecules being released into circulation with potentiation of your coagulation cascade and immune dysfunction. You also have excessive release of your stress hormones, including cortisol, epinephrine, norepinephrine, activation of your RAS system, and endothelial dysfunction. You can see it at the bottom where you have the autonomic dysregulation and cardiometabolic consequences, which include increased risk of diabetes, increased risk of hypertension, increased risk of metabolic associated fatty liver disease. So all this in totality, in a nutshell, what we are saying is a combination of these factors will cause an increased risk of your major adverse cardiovascular events, which include things like myocardial ischemia, atrial fibrillation, heart failure, sudden cardiac death, strokes, and so on. So where do the incretins come in all this? Now, a bit of history. Over 100 years ago, this incretin concept came up. And in 1902, we had the Bayliss and Starling's discovery of what we call secretin. And later, a different scientist hypothesized that gut extracts contain a hormone that regulates the pancreas and showed that administration of gut extracts, so those gut extracts are what now we call the incretins. And by that time, they had not yet come up with the name incretin, yeah? So they said that these gut extracts reduce the amount of urine sugars in patients with diabetes. And this was presumed to be through stimulation of the pancreatic beta cells. Much later is when Labar, another scientist, purified the glucose-lowering element from the gut extracts and named it incretin. Now, of the two incretin hormones that have been extracted so far, we have the GIP and the GLP-1. And I'd mentioned a bit about that initially when I was introducing the topic. So you have your GIP, which is your gastric inhibitory polypeptide, and you have your glucagon-like peptide 1, which is your GLP-1. For the GIP, it's a 42 amino acid hormone secreted from K cells of the upper small intestine. So if you remember your physiology, the K cells would mainly be found around the duodenum and the jejunum. And then you have your GLP-1, which is a 31 amino acid hormone secreted from the L cells of the lower intestine, and they're also found in the colon and the rectum. So following this discovery of the incretins, it's been a long journey of discovery and functional verification of these particular hormones. So you can see that graph from 1980 all the way to date, the number of publications that have been there. And you can see as of now, we have almost 4,000 publications just around these incretins. And remember, we have even some of these publications that are not in the public domain or certain smaller studies that have been done within facilities. So the journey has been long, but it has been very beneficial because we've come from a point of looking at them specifically for the management of diabetes to 2026, where they are being used across board for cardiovascular health, for renal health, for neuroinflammatory and neurodegenerative disorders, and so on. So just a note in terms of the first registration of your GLP-1 arrays, exenatide, which was the first one in 2005, followed by liraglutide in 2009, and then 2014 all the way to 2017, 2018, where we now had the dulaglutide and the semaglutide receiving approval for marketing in the US and then, of course, the rest of the world. And then in 2022, the twin creatine tirzepatide, which has a combination of the GLP-1 and the GIP, and we'll look at the benefits of that. So the GLP-1 receptor agonists, based on that history that I've given, have transitioned from just simple glycemic agents to multi-system therapies with therapeutic effects that are largely attributed to their ability to not just manage weight in terms of appetite and metabolic health, but also the various cardiovascular pathways. And in that statement, you can also add the renal and the neurological benefits of this, because the studies keep coming out and the benefits are being discovered daily. Beyond blood glucose control, of course, they offer all those benefits that we've mentioned. And when we look at it separately in terms of GLP-1 and your GIP, you have the multi-organ effects, and this is just a simple pictorial showing you the effects on the brain in terms of that perception of satiety, which then plays a big role as far as that feedback mechanism that enables the patients to have learned behavior that enables them to achieve weight loss. You have the effects on the pancreas, where I would like you to look at both the right and the left side of the screen because we have GLP-1 in red and GIP in blue. So when it comes to the pancreas, they basically work the same way by increasing the insulin secretion from your beta cells. The difference then comes in terms of glucagon, where you have the GLP-1 decreasing glucagon, but the GIP increasing glucagon. I know you would ask yourself, doesn't this then cancel out the effect? But when you have a combination of the GLP-1 and GIP in your dual therapy agents, you find that this effect is not pronounced in terms of a countering effect. The drug holistically still becomes more beneficial as opposed to having a counteractive effect. Then, of course, your other good benefits that are across board, which are your beta cell proliferation and decreased apoptosis. In terms of the side effects, you have your GLP-1 causing the GI effects that we know about: increased nausea, decreased gastric emptying, where the GIP doesn't have that much in terms of the GI side effects. And currently, we know that the dual agent containing the GIP actually is better tolerated by patients compared to the GLP-1 agents that are standalone. Then, in terms of the liver, you have your GLP-1 having an effect in terms of decreasing hepatic glucose production, and in the adipose tissue, increased insulin sensitivity. The GIP then comes in terms of increased lipid buffering capacity, decreased triglycerides, and increased insulin sensitivity. When it comes to things like dyslipidemia, of course, both the GLP-1 monotherapy and the dual in terms of GLP-1 GIP have been seen to have an effect in terms of lowering your LDL and your triglycerides. So again, an extended benefit in terms of dyslipidemia management. This again, very similar in terms of the target organs. Maybe I'll just point out the ones that were not in the previous diagram in terms of the muscle, where there's increased glucose uptake and increased insulin sensitivity. In the kidney, where we have decreased albuminuria because of the pathway that we discussed a few minutes ago. And I think the other one that was not in the previous diagram was in terms of the benefits to the bone as far as potentiation of bone formation and decreased bone resorption. And it's no wonder these particular molecules are also becoming of interest in terms of management of rheumatological and bone conditions. Now, when we focus on the cardiovascular system, you can see the various receptors for those incretins and where they are found. And this would include your atrial cardiomyocytes, the ventricular cardiomyocytes, endocardial cells, and that's in the preclinical studies with mice, and also on the vascular smooth muscle cells. So one major mechanism of action of these drugs is in terms of inducing an anti-atherosclerotic effect, where you have decreased plaque progression by reducing macrophage infiltration, foam cell formation, and matrix metalloproteinase 9 expression, leading to more stable and less vulnerable plaques. So once you have that overall decrease in terms of your plaque progression, in effect, you expect better outcome, better prognosis as far as blood vessel integrity and blood vessel, or rather vascular oriented disease or pathology, as it were. The other way in which this atherosclerosis is reduced would be through the suppression effect on your pro-inflammatory pathways, and so on. We've already talked about your lipid metabolism, and in terms of the effect on your triglycerides and your low density lipoprotein, and increased fatty acid uptake by white and brown adipose tissue, which then makes that metabolism of your lipids easier with less ectopic fat deposition and storage. When we look at endothelial function improvement, we're talking about decreased plaque progression, as we've already mentioned, as well as overall improvement in terms of blood pressure reduction and heart rate modulation. How do these GLP-1 arrays, or how have they been found to reduce the blood pressure? So they have been associated with increased atrial natriuretic peptide, increased urine sodium secretion, increased vasorelaxation, and also effects in terms of heart rate and systolic blood pressure. When we talk about heart failure reduction, of course, the STEP HFpEF study, which happened a few years back, demonstrated clear benefit in terms of improved cardiac function in patients with heart failure with preserved ejection fraction. But now we have new data as of 2025 from the SELECT trial that is also showing benefits in your heart failure with reduced ejection fraction population. And it does this by reducing epicardial adipose tissue, mitigating cardiac fibrosis, and increasing cardiac glucose uptake and ATP production. When we look at aggregate data as far as major adverse cardiovascular events, and now we'll shortly go into the specific trials that have been done and quoted heavily, where they have demonstrated reduced cardiovascular death, non-fatal myocardial infarction, and also impact in terms of strokes. We have three major trials that have been quoted heavily, and that's the SELECT trial, the SUSTAIN 6, and the LEADER trial. And we'll also look at the PIONEER 6 trial. So in terms of this evidence of semaglutide effects on the cardiovascular outcomes, we've had a series of trials, mainly looking at those major adverse cardiovascular events, or what we call the MACE. From 2016, where we had the SUSTAIN 6, involving about 3,200 patients. It was a non-inferiority trial, which included a study population of patients with type 2 diabetes. About 28% of them had chronic kidney disease, and over 80% had cardiovascular disease, and an mean BMI of around 32. Then we had the PIONEER 6 study in 2019, which looked at the oral formulation of semaglutide with over 3,000 patients. Again, a non-inferiority trial looking at major adverse cardiovascular events in a type 2 diabetes study population who were put on oral semaglutide versus placebo. And again, looking at the effects in terms of which group fared better. Again, mean BMI matching the SUSTAIN 6 of around 32, and those with cardiovascular disease at around 84%. So this table, I'm just describing the trial and the study population that was involved. You can see they are highlighted in yellow. The SELECT trial, which was a real game changer, because as you can see, all the other trials included type 2 diabetic patients. In this particular trial, there was actually inclusion of patients who did not have diabetes to assess the effect of semaglutide in a patient who has obesity but no diabetes. So again, very good data and information in the current scope of practice, because you have a lot of patients coming in for these medications. They are not diabetic per se, but have obesity and clear cardiovascular risk. So it will be good to know whether these medications are safe and beneficial, because they do come with their own pros and cons in terms of deciding whether this is actually a good choice for your patient. So we had other studies, the FLOW trial in 2024, and more results from the SOUL trial in 2025, which also looked at the oral formulation, this time involving almost 10,000 patients. It was a superiority trial in the type 2 diabetes population who are put on oral semaglutide. So this is a summary of the publication from the SELECT trial. And as we've said, it was the first cardiovascular outcome trial to evaluate superiority in major adverse cardiovascular events reduction for an anti-obesity medication. And here we can call it anti-obesity medication because the approvals that transition semaglutide from primarily being approved by the FDA for use as a diabetic agent. And then they sent back, of course, the investigators to do specific trials to be able to justify the use in terms of weight management and other cardiovascular outcomes. Remember, when it comes to the FDA, in terms of your research and drug development, if you designed a clinical trial for a specific indication, and then you observe that there are other benefits, or other observations that you're seeing from the molecule after it has been approved, you have to go back and conduct fresh studies for the particular outcome that you want to now include as an indication for that particular drug. So that's what happened with this medication, semaglutide specifically, where initially it was meant for blood sugar control, benefits observed as far as renal, cardiac, weight, and fresh studies and approvals had to be sought for the same. So, to summarize it in the interest of time, I chose to look at a very good paper that did a meta-analysis in terms of all those studies that I've mentioned. So aggregate data to be able to see, does semaglutide fare stronger, or is it deemed to be superior to the placebo that was used in the trial? And you can see for the SOUL 2025, FLOW 2024, SELECT 2023, Pioneer 6, and SUSTAIN 6 trial. When you look at that forest plot, all the data favoring semaglutide. When we look at the major adverse cardiovascular events that were study endpoint across these studies, you can see in terms of cardiovascular death, the semaglutide group, which on your screen is to the left, actually had lower odds of developing that particular outcome. Again, lower odds of non-fatal MI and lower odds of non-fatal stroke. Overall, the odds favored semaglutide. When we look at the major adverse cardiovascular events across the subgroups, and here they are considering cardiovascular disease, diabetes, age above 65, which is considered elderly, presence of obesity and chronic kidney disease, presence of heart failure, concomitant use of your SGLT2 therapy, and history of previous stroke. Again, if you look at that forest plot, all of them to the negative side of 1. So that basically means that most of the data actually favored semaglutide as that particular subgroup of patients in the study population had lower odds of developing the major adverse cardiovascular events. So when we compare the cardiovascular outcome trials that looked at the oral and injectable semaglutide, because both options are available, the major ones would be your SUSTAIN 6 and Pioneer 6 trials, where SUSTAIN 6 investigated the injectable semaglutide, and the Pioneer 6 looking at the oral semaglutide. Both studies assessing cardiovascular events in people with type 2 diabetes and high cardiovascular disease risk. Again, if you look at the results on the screen, you see that most results as far as your major adverse cardiovascular events, the incidence of cardiovascular death, non-fatal MI and non-fatal stroke were actually found to be less in terms of occurring as a first-time event in the group that was on semaglutide. So again, the data favoring semaglutide for both the oral and the injectable preparation. So all these findings have contributed to the recommendation of your GLP-1 arrays, including semaglutide, for cardiovascular risk reduction in patients with type 2 diabetes. And we do remember the papers from 2-3 years back, the ADA ESD consensus reports, which included your GLP-1 arrays as anchor molecules in patients who are diagnosed with diabetes, coming in for the first time with significant atherosclerotic or cardiovascular disease risk or renal risk. So all this evidence goes towards informing the kind of guidelines that we use in practice now. And that was the basis of looking at what exactly informed our current guidelines. Again, just as a matter of emphasis in terms of trial, which not only gave us cardiovascular outcomes as far as type 2 diabetic patients, but was very emphatic in terms of the effect of semaglutide in your obese non-diabetic patient. So when we are prescribing semaglutide, if you want to give the subcutaneous semaglutide, and we're coming to almost the tail end of the presentation, the subcutaneous kind given once weekly, and in terms of dosing instructions, of course, you want to warn your patients about the potential side effects, which are mostly the GI effects that we've already mentioned. The particular formulation will require refrigeration, of course, counseling in terms of adherence and compliance, but also full knowledge of any cost implications that may be there to the patient if their insurer doesn't cover, and so on, so that you don't start a patient on it and then they have breaks in between. It can be very frustrating when a patient, even if whether it's for weight loss or for cardiovascular benefit, when they are not seeing the results because of staggered treatment due to lack of affordability, can be quite frustrating. So let the patient know the pros and cons in terms of the science or the medical efficacy of the drugs and everything around it, including the cost, so that they're able to prepare, able to talk to the insurer, able to prepare themselves in terms of affordability. And we do know that now with a lot of generics coming in, the prices have gone lower and lower, and more patients will be able to afford these very, very beneficial drugs. For the oral semaglutide, once a daily administration of the tablets, no refrigeration required. The GI side effects may still be there. So because of that, you try and work with the patient's diet. Of course, I cannot emphasize the inclusion of a multidisciplinary team, including a nutrition expert, including your physical exercise specialist, so that everything goes hand in hand. When you're targeting your cardiovascular benefits, nutrition has a role and your physical activity also has a role. So multidisciplinary teams, so that whatever medical therapy we are prescribing then has the maximal benefit to the patient. When it comes to dosing, for the oral, we normally start at around 3 milligrams and then increase it every 4 weeks as tolerated. In our market, we have up to 14 milligrams, but in other markets, you can find a tablet of up to 25 milligrams. Of course, you scale it up as tolerated, and you want to cap it at where the patient can tolerate. There's no one size fits all. We can't say all patients escalate to 14 milligrams or 25 milligrams, because sometimes the side effects are what dictate how high we can go. And if you get the benefit that you need at a lower dose, then the better for your patient. For the injectable kind, initiate at around 0.25. Some patients start at 0.5 and titrate upwards. The 2.4 milligrams, not very well tolerated in our population, but we do have a few patients who are on it. But you find that in terms of real world evidence in our clinics, most of the patients end up on a maximum of around 1 milligram. But in terms of the data, you can go all the way up to 2.4 milligrams for your cardiovascular outcome benefits and even for maximal weight loss. Although when it comes to weight loss, patients behave very differently. There are a lot of individual characteristics that have been studied with a lot of neuroscience information behind it in terms of patients who do very well on 0.5 milligrams injection and others just plateau at certain milligrams. So a lot of studies coming out to be able to explain the inter-individual differences in terms of such responses. The good thing is, as we've seen from the trials across board, independent of your weight loss, independent of the effect on your glycemia, this medication has clear cardiovascular outcome benefits. In terms of duration of treatment, currently we say it depends on your indication. If you're targeting the weight loss, then at 12 to 18 months, you want to see whether you've achieved maximal benefit and have the discussion with your patient about whether the intensive behavioral therapy has worked, whether they are good or on board with their nutrition and physical activity and so on, and you can make the decision to wean off. For patients who are on it for cardiovascular benefits, then it goes without saying, just like your SGLT2s, then the medication becomes part of your long-term therapy. So you'll want to find a dose that a patient is comfortable with to be able to get the most benefit out of it in terms of balancing benefit versus the risk. So in terms of our key takeaways, we've looked at the trials, particularly the SELECT that suggests that semaglutide should be considered a disease-modifying agent for cardiovascular health rather than just a glycemic control or weight loss medication. The cardiovascular benefits are multifactorial, including your improved blood pressure, reduced inflammation, and reduced body weight, which of course has extended benefits in terms of cardiovascular risk. Consider your side effects, including your GI intolerance, as this was the main reason for treatment discontinuation in most of these trials. So I think that brings us to the end of the presentation. I'll hand it back over to the moderator to be able to take some questions. Thank you.
Thank you so much, Daktari. You have taught us a lot, reminding us that as much as there is a lot of hue and cry out there for use of the GLP-1s for weight loss, let's also remember that these patients have a high cardiovascular risk, and these medications modulate against the cardiovascular risk, and the patient actually has less risk of stroke, heart attacks, and major cardiovascular events can be significantly reduced if these medications are on board. Thank you for answering also the question about the duration, because that was the first question I was going to ask. If a patient stops the medication, they've achieved their target weight, their blood pressure much better, good glycemic control, their behavioral, patterns towards healthier eating and things there's definitely a modification in that direction. If the medication is stopped, with the cardiovascular benefit remain, some sort of legacy effect. But I think you have answered it, unless you want to say more on it. But I think from what you have said, most of the time it looks like you do not get that cardiovascular benefit being sustained as you would if the patient was still on the medication. Or what is your take on that?
Thank you, Dr. Omari. Yes, in terms of that legacy effect, remember the term legacy effect, just as the word suggests, would be based on more longer term data. We now have running prospective cohort studies of clients who've been initiated on this. And we hope that in the next 5 to 10 years, we'll really be able to understand these molecules better. Remember, they've been around for less than a decade. And in terms of the cardiovascular outcome trials, it's even less than 5 years.
Yeah.
So we are understanding them on the go. For now, I don't know whether we can strictly define legacy. It's been a short while, but in terms of sustained benefit for patients who are in the clinical trials, yes, we do see the multi-organ benefits. How long they can be sustained, I think it's fair to say maybe let's wait for the longer term data that should be coming out maybe in the next 5 to 10 years. Thank you.
Okay, thank you so much. So we'll start with the first question. Len Simi wants a comment on the use of semaglutide in obese children who are on hydrocortisone therapy due to ADH. Anything you might want to weigh in on that? Using semaglutide in obese children.
So that one, I think for me, the recommendation would be work very closely with the pediatric endocrinologist. By all means, don't prescribe this blindly. We do have the guidelines which have age cutoffs, and some give you 14 years, others 16 years. So you want to be, and this is largely based on the kind of population that has been involved in terms of the clinical studies. So, in terms of the younger children, I think we want to trend a bit more carefully, with
Yeah.
a bit more caution, in terms of, the side effect profile and the long-term effects of these medications. And children being a vulnerable population, that's why you see we sort of walk on eggshells when it comes to involving them in terms of long-term use of some of the newer molecules. So I would say refer to a pediatric endocrinologist. Yes, it can be used, but with a lot of caution, again, depending on the particular age of the patient.
Okay. The next question uh, is the dosing of the semaglutide based on weight? Is it that, if you're, you have a higher baseline weight, maybe your dosage is higher over time, or, I think somebody just wants to have an idea about how to go about it.
All right, that's a really good question. Which is very practical because we do have the medications where we dose per kilogram body weight.
Mm,
So your GLP-1 arrays, no, we do not base it on weight. As I indicated when I was talking about dosing, normally you start low and then titrate upwards based on what your patient can tolerate. So it's sort of a unified approach across all the weight classes in terms of starting low and titrating up. And as I mentioned, currently you may not be able to sort of predict from the outset which
yeah.
patient will respond quicker. You may find, for example, in my clinic, I have very high BMI patients who, within 3 months of treatment, lose a chunk of their weight, some 20, 25 kilograms within
Mm,
3 to 6 months. And you have others with lower weight who really
mm,
stagger as far as that weight reduction. So that's what I was talking about, the inter-individual differences in terms of how we respond to the incretins. I think it's studies that we are excited to see come out,
mm,
whether there's some, neuroscience behind it, or, some genetic characteristics that influence this and so on. So we are not really able to say because you're of a higher BMI, let's start you at 1 milligram. No, you start at the lowest tolerable dose and then scale up as tolerated.
So thank you for emphasizing, especially the issue of starting low. I think sometimes the patients are also, they want to be on board and get to higher doses quicker. So they want to shorten that duration. They want to take the lowest dose for a shorter time. Can't I take this for 2 weeks? Then, go up. But the likelihood that the GI symptoms might be high, and the tolerability likely to be, not, the patient may not tolerate, are some of the things they need to be told that, just give it time, be patient, give it time, give your body time to adjust, and the doses will be adjusted upwards as you tolerate. So on the same issue, now that the doses are escalated over time, once, for example, they have achieved their target in terms of weight loss, or whatever it is that that initiated the start of that medication, is there a step down, sort of regimen, or, once the patient gets to 14 milligrams, has been there for 2 years, has significantly, improved a lot on their cardiovascular risk and blood pressure, blood sugar, all of a sudden we get to zero? Or is there something like a step down approach to withdrawing the medication?
That's another very interesting question. So the approach to and I think the person who asked the question is mainly looking at it in terms of the weight and not
Yes,
necessarily the
yes,
cardiovascular outcomes and other
yeah,
attendant benefits.
yeah, yeah,
Um, so in terms of the weight, one thing I want to emphasize is when I put up the chart on obesity classification and how
yeah,
we decide how to treat.
yeah,
I think it's important to know that there's a pyramid that we use or a scale up in terms of nutrition and physical exercise, medical therapy, all the way to surgical therapy. Now, when it comes to weight, the truth is, if you look at it critically, your incretin effect is essentially also supposed to help the patient with learned behavior in terms of eating small portions, appetite suppression, and so on. So weaning off again is very individual. There is no blanket way of saying you on 14, you've achieved your weight, will now come off. Remember,
mhm,
again, by definition, currently, there
mhm,
is the mention of the obesity being the chronic disease of adiposity, which may be relapsing. You may
yeah,
also want to consider that your patient may be having that relapsing kind of where you
yeah,
come off
yeah,
medication and they gain the weight back. They
yeah,
have the surgical procedure done. They take their GLP-1 arrays or twin incretins for some time. When they stop, the weight comes back.
yeah,
So there is not, again, a one size fits all in terms of step down or weaning
mm,
off. It depends on the patient. You may start coming down on the doses if they're okay in terms of their nutrition, their physical activity, everything is fine. They're maintaining the low weight. That is fine. You'll come off. You can reduce, for example, if you're on the oral 14, 7, 3, or if you're on the injectable, titrate downwards from 1 to 0.5 to 2.5 and come off as you try and observe whether that metabolic adaptation, in fact, that's the right
mhm,
word, whether that
yeah,
metabolic adaptation has happened.
yeah,
But it's done in a very calculated manner, such that you just individualize treatment the same way we do in hypertension, same way we do in diabetes. When your patient achieves target or you feel like they're in remission, again, you just work with the individual patient. So similar to this, I think that would be my take. Again, still too early in the day to tell, but as we continue with our real world observation of how patients are faring, I think when we have these discussions in another 2 to 3 years, we'll have a lot more to say. But for now, work with your patient, titrate downwards, but also make sure that they have the lifestyle adjustment that is required to keep the weight off.
yeah. That's a very elaborate answer. It is true. We have seen patients who their metabolic, I think their weight, fluctuates quite dramatically, and they're able to lose a lot of weight over a short time, and they're also able to gain a significant amount of weight also over a short time. Some of them, of course, the challenges that you've mentioned, probably, the lifestyle modification is not consistent, and so that again becomes something that, as we manage patients, and the individual variability, and then we see how best to advise them and how best to manage them. I think the other questions are pointing more towards probably what our sponsors will be talking about. Because people are asking about price ranges, where can they get best deals for some of these medications, and things that I think our sponsors will be able to mention something because of time. I think it would be important to highlight the summary, as you've said, that semaglutide is a medication that, yes, was initially studied for, glycemic control in type 2 diabetes, was shown to have significant cardiovascular outcomes in terms of reduction of MACE, has studies that have shown the cardiovascular outcomes can be significantly reduced apart from just the other targets like lowering weight, the cardiorenal benefits that we have seen, and that it is something to consider if our patients have high cardiovascular risk. So I think in the interest of time, let's give our sponsors a chance. They can be able probably to answer the other questions about the price ranges, where can these medications be found, and what are they bringing to us for the benefits that we can pass to our patients.
Thank you very much, Dr. Omari. I hope you can see my slides.
Yes, I can see them.
Okay, that's it. So thank you also, Dr. Oliver Akunga, for the wonderful presentation. And indeed, as Cosmos Limited, we assure the association and the medical fraternity of our continued partnership. And today I'll want to share on our product, that's or a few of other products, but largely on this. Is there a movement, Dr. Omari?
So we're still on the first slide.
How about now?
Yes.
Yeah, definitely. Cosmos Limited will continue partnering with KDSG on this webinar series, and we are privileged to be the first company to join you this year, and we'll continue with all this scientific engagement. And just a brief history, we always talk about the quality that we bring to the market. And as one of the first manufacturing companies in Kenya, we still believe in offering quality medicine for the patients. And as mentioned, the objective of our brands is always patient-centered. We ensure that they get the best in the market at the most competitive prices. And in line with the government, we also are part of the universal health coverage. And ultimately, when the medication is cost-effective, we are definitely on the line of promoting patients' compliance to treatment. The first question I'll answer right away is about the cost of our glucoset, which is the first in the market. Remember when we launched, we had prices that were a bit high, but our director assured us that once the APIs became more cost-effective, we'll make glucoset more affordable to the patient. And keeping to our word, this year we've lowered the prices as highlighted, the 3 mg. We are currently retailing it at the wholesale price of 3,000 for a pack of 10s. So from the original 15,000 monthly dose, it has come down to an average of 9,000. And this shows our commitment to that we keep our word when we talk about making affordable medicine. And we are assuring you, even in the near future, the medication will be more cost effective as the API become more cost effective and the usage becomes more so higher. The 7 mg is retailing at 3,500, but the 14 mg is still a bit high for the API, so still at 5,000. But as we mentioned earlier, or Dr. Akunga mentioned, if a patient is managed on the lower strength, you can still sustain them on that. Not to forget that the FDA recent approval of semaglutide, the oral semaglutide, having weight reduction benefit, and more so the essential medicine listing of semaglutide as an essential medicine. This is one of the drivers that we have and will purpose as a company to ensure that it becomes more affordable over time. And for now, these are the current rates we have in the market. And this is both in the hospitals and also at the open market. So the patients can get them everywhere. So lastly, what Daktari has been talking about, I know she has covered most of the science. So I'll be very fast on my presentation. And ultimately, as highlighted, the cardiovascular disease burden is not only the leading cause of morbidity and mortality in patients with type 2 diabetes, but also has the highest contribution in terms of cost when you're managing a patient with type 2 diabetes. The rest of the numbers that Terry has mentioned, but as old as 2000, the cardiovascular disease was still a very huge concern and increased mortality and stroke incidences by 2 to 4 times. So managing the cardiovascular issues became quite a priority. And of course, we've seen also obesity being a huge cause of all these cardiovascular issues. So I'll go straight. Also, this is as old as 2015 that showed how a patient with cardiovascular diseases has, shorter lifespan compared to a patient with only diabetes or one without diabetes. So to the subject of the day, definitely Dr. has mentioned this a lot. There's a SOUL trial, and I'll not go so much into the details about the way it was structured, but this was released last year, and you'll see the benefits of oral semaglutide on the 3-point MACE or on the 5-point MACE is quite clear, as highlighted on the next slides, that for your patient, sorry about this, be it from the HbA1c and base and BMI change, it is quite clear that the oral semaglutide had better outcomes compared to the placebo. In terms of blood pressure management, the same. The curves clearly show that the oral semaglutide had more benefits. And indeed, you had talked about the lipid profile and the cholesterol levels and all that. It still showed quite good outcomes as compared to the placebo. And overall, as compared to placebo, as Dr. had mentioned earlier, the 3-point MACE, you find that oral semaglutide had very high or was mostly favored in this chart as shown. So apart from that, this conclusion is quite clear that it improved the overall or several ASCVD risk factors. And with this in mind, it will be quite important to consider putting your patient on the oral semaglutide, as already you can see, even from the first OASIS trial, you could go up to 50 milligrams of oral semaglutide. But as you mentioned, the SOUL trial had 25 milligrams, which was still tolerated by most patients based on how they took it. And I'll be very straight to the end of this, the conclusions, that even with the 50 milligrams of semaglutide, of oral semaglutide, patient with or without diabetes were able to get good clinical outcomes, be it in weight management and also definitely on the HbA1c. Straight up to the current trial or the STEER study that was recently released, and is still overall on the semaglutide versus tirzepatide in terms of lowering the risk factors. It still favors or shows a lot of uh, favor to the semaglutide, especially on the 3-point risk. This is as late as last year, and this is what we really want to highlight, that even in terms of the 3-point MACE, with semaglutide as a class, you have up to 57% reduction. So this was quite recent, and it's part of what we'll be discussing, and we can only request you to pass the benefit of our glucoset for your patient. Dr. has already mentioned the dosing schedule, and many patients are tolerating it. And if need be, no need to go up to the 14, or if need be, you can titrate up to the 14. And if the patient is following all these guidelines, they're able to tolerate the medication. So the rest of is just a reminder on our products. I know we have a wide range. Most of them are well aware to you, so I'll just highlight the likes of our dapagliflozin and metformin, lysate met. We also have a glucoil met, that's vidagliptin and metformin, and we'll continue offering the novel molecules in the management of type 2 diabetes. For the antihypertensives and statins, the Carditan is our losartan potassium. We also have the Telmicos range with combination with Rodipin, and also the statins, be it atorvastatin, avastatin, and rosuvastatin is our Lipecos. We are also quite strong in the heart failure segment, and soon we'll be bringing in our finerenone. In the meantime, we have glycid, dapagliflozin, Dicard, the sacubitril valsartan, Vidol is our carvedilol, and Tibina atosemide. And in terms of NOACs and anticoagulants, we have the first branded rivaroxaban in the market, Hatiz in the strength of 10, 15, and 20. And in the interest as a physician, I believe you get patients with hyperuricemia and gout. For that, we also have our Fibron, that's our Febuxostat, 40 and 80 milligrams. And recently, as late as last year, we launched our Costapin, which will be sharing more information in the near future and having more launches and interaction with the physicians. That's our combination of paracetamol, codeine phosphate, caffeine anhydrous, and oxylamine succinate. So in terms of the same patient who may have hyperuricemia or pain, we have also these solutions. So thank you very much, and back to you, Dr. Beatrice. And I really appreciate the continued partnership we have with you. Thank you.
Thank you for highlighting oral semaglutide, the strengths that are available, the costs. I think somebody also wanted to find out if insurance takes this, covers these medications.
I'll say yes, we have a number of insurance companies and it's being taken up quite fast. And especially considering cost was a major factor, but now with the lowered price, considering in some instances, you can get it as low as 10 to 11,000 shillings, and you put out a patient from other medication. So the cost factor was quite an issue, but the benefits really stand out. And yes, it's being covered by insurance companies.
So I want to thank you so much, Esbon, on behalf of Cosmos, for doing that presentation and letting us know about what is available. I also want to thank Dr. Olive for the splendid presentation. You have highlighted the cardiovascular benefits of GLP-1s, and I think set a high standard for the beginning of the year. So we're also hoping to have more empowering presentations that are going to make our practice even better. I want to thank ZP on behalf of KDSG also for setting up this webinar and ensuring that you got all the links on time and that this webinar was able to start, and Dennis. So from us as KDSG, we thank you for your participation. We thank you for listening to us, and we hope that you will get another chance once again to come on when we send out when the next presentation will be. Otherwise, from our side, we want to wish you all a good evening, and hope to see you again online in the near future.